Hello,
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 hello.
hello, hello, hello.
Yeah. So ಓಕೆ ನಾನು ವಿಡಿಯೋ ಪ್ಲೇ ಮಾಡಬೇಕು ಆವಾಗ ಅದು ಮ್ಯೂಟ್ ಮಾಡ್ತೀವಿ ಇದರಲ್ಲಿ ನಾನು ವಿಡಿಯೋ ಪ್ಲೇ ಮಾಡ್ತೀನಿ ಹಾಂ ಓಕೆ ಅದು ಟೈಪ್ ಅಲ್ಲ ನಾನು ಇದರಲ್ಲಿ ಯು ಆರ್ ಹಿಯರಿಂಗ್ ಮ್ಯಾಮ್ ಓಕೆ
Start. Good morning to all the delegates, the resource persons, and everybody who has joined for the day one of International Conference on Health Profession Education being organized by University Center for Health Professions Education, Shri Devaraja's Academy of Higher Education Research, Kolar, Karnataka. Namaste to all of you. Namaskara. We start with our first session of the day. It's a very important session because as health profession educators, our outcome is a competent health professional, and the health professional's outcome is improving the health parameters or improving the health outcomes of the country or wherever the health professional works. Now, when we look at the paradigm change that has happened recently in the practice and the requirements of the health professionals, it has shifted from an individual practice to a community-based practice or a team-based practice. And when we talk about team-based practice, we require a lot of collaboration. We require a lot of interprofessional expertise and competence. And that's the reason why today's first session, and we have got with us Professor John H.V. Gilbert, who will be shortly joining us. He is Professor Emeritus, University of British Columbia, Adjunct Professor, Dalhousie University, and he is in fact our own Dr. T.M.A. Pai Endowment Chair in Interprofessional Education and Practice at Mahe, Manipal. He is also an adjunct professor, University of Technology, Sydney, and is a senior scholar, WHO Collaborating Center on Health, Workforce Planning and Research, Dalhousie University, and is founding chair, Canadian Interprofessional Health Collaborative. So we have got a very experienced person to give his talk on interprofessional education. What do we learn, or what should we teach, or what the student should learn in interprofessional education? How that teaching should be implemented in the form of practice, and what are the outcomes, that is the care, patient care, or the health care that should uh, be targeted at. And he'll be talking on exploring two core principles. So we will run a video which has been sent by him. And once Professor Gilbert joins, then we will take the questions and discuss with him. So over to the presentation.
Good morning, everybody. It is a great pleasure and an honor to be speaking to you today at the International Conference on Health Professions Education. I'm going to talk about interprofessional education, learning, practice, and care, and I'm going to abbreviate it as IPECP. And I'm going to explore two core principles which have been around for quite a long time and which we are still discussing. Yesterday was not the beginning of history. I think it's very important to underline that with respect to IPECP. In 1964, John McCreary, who was Dean of Medicine at the University of British Columbia, my university, wrote a prescient article in which he said, as you can see, all of these diverse members of the health team should be brought together during their undergraduate years, taught by the same teachers in the same classrooms and on the same patients. And that was an ideal which essentially we've been following for the last 60 years, trying to work out how to learn together in order to practice together. And we're still thinking about, the issues that surround this statement, which was made by John McCreary. Well, in 1997, the first meeting of All Together Better Health took place in London. It was organized by Hugh Barr, and it was a very, very interesting meeting because it was the first time that people interested in interprofessional education or person-centered collaborative practice actually came together at a conference. And they wanted to discuss two major questions. Interprofessional education improves collaborative practice, and interprofessional collaborative practice improves the quality of care. Those were the two big debating points at that time. And in actual fact, they're still big debating points. Does interprofessional education improve collaborative practice? And does interprofessional collaborative practice improve the quality of care? Well, I think I'm pleased to tell you that we have some pretty good data now to support these contentious principles. But I was thinking a long time ago about quantitative matters as opposed to qualitative matters. Today, most of the work that is done in interprofessional education for collaborative practice is mixed method data collection. And I was thinking then, and this was 50 years ago, is the question a kind of quasi-null hypothesis? That is, there is no difference in collaboration to improve quality of care provided by health and human service professionals who are educated at the pre-licensure level to learn with, from, and about each other, as compared with those professionals who are not so educated. And I must say that in those days when I was really a quant, people didn't take very kindly to kind of reducing human behavior to a null hypothesis. But it is an interesting hypothesis. Is there a difference? That's what those two first questions are asking. Well, when we got to really thinking about the difficulties that are associated with learning together to work together, we put together a proposal to the World Health Organization around the principles that I'm talking about, these two principles. And over a 2-year period, colleagues around the globe worked together to produce the framework for action on interprofessional education and collaborative practice. And you can find this online. I think now, the last time I looked at it, been referenced more than 12,000 times. And in that framework, we tried to look at those two principles and also how they applied to every kind of culture that we were looking at, because clearly in middle-income countries, as opposed to high-income countries, the level of health services, and I want to say health and social services, are quite different. So we tried to look at those objectively and figure out, what were the similarities and what were the differences? Well, clearly, what the first principle was talking about was to achieve and interprofessional collaborative practice ready workforce, because we are all very concerned about workforce. We're always being told there are not enough nurses, doctors, etc. But in order to kind of smooth out the edges of that huge issue, we said, well, you know, collaborative practice might help to reduce the tremendous demands on more of the same and get people actually working together. And then as we were building that interprofessional collaborative practice, we would be looking at how do we do it so that we achieve optimal health services. It's an issue, another issue that we addressed in the framework. And then when we looked at health and education systems together, and I think we probably all know that there's a big separation in many countries between health and education systems. But when we looked at the way that they were kind of divided across the world, we said, well, in order for us to achieve collaborative practice, you know, a workforce that is actually ready to work collaboratively, then you have to improve health outcomes through interprofessional education and learning. And I think that was very clear as we went through the exercise of looking at what was being done around the globe in terms of learning together. Well, what we discovered when we looked at these issues was there were some really big challenges to get people to learn together so that they could work together. First of all, it was very clear that there was not a work plan that was adopted and adapted across many different cultures in order to get this to work. There was no idea about how to put things together. And then even if there were some places where there were work plans, and in some of the highly developed countries, there were the United States and Canada, what we were lacking was a robust evaluation framework. So we had a work plan, but we still hadn't worked out, well, you know, downstream, how are we going to evaluate what it is that we've done? And then another big challenge was how to fund it equitably and accountably. The idea was, oh, well, we can do interprofessional education. Here's $5 and here's a desk, you know, just run it off the side of your desk for $5. And yeah, you could do it Friday afternoon when it's raining in Vancouver. It was crazy. There was no notion about how to be wise and strategic about the funding that was necessary to bring health and social care professions together in order that they could, in fact, learn together. And then even if we had some notion about how to fund equitably, we still didn't know how to make it accountable to the kind of organizations within education and within the practice settings. You know, what was the accountability and who was it accountable to, et cetera? Another big challenge. And then, of course, always there's this problem of collaborating with all the concerned parties. Now, by that we meant, and we still mean, collaboration in many different ways with many different people. It's not just collaboration in the education system, collaboration in the healthcare system, and it's not just collaboration between those two systems. There are other pieces outside of those two systems which are necessary for us to collaborate with. For example, those organizations that provide services that are really essential for the provision of excellent healthcare. Sometimes those organizations are completely outside the healthcare systems. So, you know, collaborating with all the concerned parties, it still is a challenge getting people to work together. And then, of course, within the organizations, both the education organizations and the practice organizations, there was kind of not a lot of idea about the kind of space that should be provided and what the administrative support should be for this particular kind of activity. And again, it's very funny to me when I look at the way in which programs were established, where people say, well, we've got this, you know, small room, and you can have our secretary, you know, at least for 1 day a week, but we can't afford to give you more than that. Honestly, what we discovered was you simply cannot build interprofessional education for collaborative practice that way. These challenges remain in some ways still as we try to organize health and social care and the health and social care systems allied with education. These challenges are still there. Work plans, evaluation framework, equitability and accountability. And although we have now some very interesting data on how to move past these challenges, every time we move to a new place, the challenges they're not still there. They're then reworked again. People say, well, we can't do it because, et cetera, et cetera. So what are some of the critical success factors? Well, what we discovered was that we really had to work with our governments, both at our provincial level in my country, Canada, and at the federal level, around the issue of interprofessional education for collaborative practice as a workforce strategy. That is, the better you could put together an interprofessional workforce, the better chance you had of improving the way in which the workforce was structured. And that structure is, of course, at institutional levels, it's the structure, across a health ministry or across an academic unit. And then within the health ministry and the academic unit, the kind of organizational levels, all the way from the chief executive officer of an organization or the principal or the president, all the way down to the people who work on the front line. That is the people who teach in classrooms and those people who are working actually in clinical practice, doing the kinds of things that are really interprofessional. We also found that as we were working through this approach to the government, was it would be great to find strategic and innovative partnerships. And so we spent a lot of time, and we still spend time, trying to find these kind of partnerships which help us to move the agenda forward. That is, strategic partnerships between some branch of government, some branch of education, some branch of the health system. A partnership that might be monetary, that is, government would say, well, here's $5,000 for doing something, or it might be strictly in terms of personnel. But those strategic partnerships play and still do play a huge role in moving interprofessional education forward. Facilitating new knowledge creation and exchanging, applications about IPs across all constituencies, absolutely critical. And it's very interesting to see how much new work is being done every year in interprofessional education. 15 years ago, there was not a lot being done. Now, I think every day across my desk comes probably 3 or 4 new articles from every aspect of the health system about interprofessional education, and every subdiscipline. It's not just medicine, it's not just nursing, it's dentistry and physio, et cetera, et cetera. Lots and lots and lots of new knowledge creation, which are kind of reinforcing our answers to those 2 principal questions I asked you at the beginning. Does it make a difference, and how does it make a difference? And then the whole notion of sharing responsibility between those who are doing and the agencies within which they are working. And that's a little more difficult. And that, of course, requires, I think, issues like scopes of practice. Are there things in scopes of practice which actually can be shared between health professions, health social care professions, and then things that between agencies can be shared, like technology, and certainly with the rise of AI, we're going to see a great deal more of that. So there's some kind of critical success factors which assure that once you have a program on the ground for interprofessional education, these kinds of things not only keep it running, but make it more mature, make it more far outreaching within communities, etc. Now, People ask me frequently, well, what's the best evidence? Well, there have been lots of systematic surveys done, and I think the one in 2016 by the late Reeves and Associates is probably still pretty good. We do know that in order for interprofessional education to succeed, you have to have good faculty development. Now, we could say about the entire, post-secondary system, yes, faculty development's essential for every specialty, every profession. We really do need that. And we've discovered that when you have good faculty development around interprofessional education, where the faculty understand what inter means in interprofessional education, that you see a kind of rise in accountability or rise in comfort with performing in this way. Second thing that they found and reported on, and I think is still true, is that the learner's view of IPE is related to many different factors. So when you ask students about interprofessional education for collaborative person-centered practice, they'll give you a range of ideas about what that really means. And what we try to do is to build kind of portfolio of instances in which clearly interprofessional education for collaborative practice is active. And one of them, of course, is things like diabetes or COPD. These are huge issues. And when we explain to students within a practice learning environment, hey, look at the people who are involved in coping with and producing help for people with diabetes, COPD, they begin to see the picture. I'll say it probably a billion times. Practice, practice, practice. Interprofessional learning comes out of practice context. It can't be done in a classroom. You have to have students standing around a person who has a problem, watching each other from different professional points of view, working on how to make that, the health being provided, healthcare being provided for that, the very best. So effective learning really is about practice context. And that means we have to think seriously about what is the syllabus, what is the curriculum that we would have to put in place in practice in order to promote interprofessional learning. And then one point that we're still very interested and concerned about, that is underpinning courses and programs with educational theories. And we have now a couple of theories which we use time and time again in trying to ensure that across programs and across cultures, these theories are producing really robust data about the best way to engage students and faculty in learning together. And then that really is folded into understanding teaching and learning processes that are involved in delivery of effective IPE. Teaching and learning, we've learned a lot about, certainly in my life as an academic. We used to say, okay, you've got your PhD, now just go teach. Not anymore. We've learned and learned and learned that you have to learn and learn. So in my university and many universities now, faculty members are expected to engage in learning how to teach. And I think that's really, really, really important with interprofessional education, because it's learning what the inter is, which makes it different from teaching your regular professional program. You have to know, what does it mean to be inter? And what does that mean about your personality as a professional when you become inter, not only professional? And incidentally, to be interprofessional, you have to be professional first. So some procedures to meet those challenges, as I said earlier, facilitate connections between important stakeholders. And that means things like ensuring that the CEO or the president, the CEO of the health system or the president of the university really understands what you're talking about when you're talking about interprofessional education, because they are very important. That person who's up there dictates or puts in place procedures and policies all the way down people at the front line. Focus the work in appropriate groups. Yes, I think it's really important to say there are some cases where you don't need anybody to do interprofessional because there's only one professional needed to perform with that particular patient. But if you think about, as I said earlier, the diabetic patient, somebody with COPD, any of those kinds of long and large entities, then you have to focus the work in those groups. Multi-site research, absolutely important. You know, if you know that somebody in X university is working on some of that learning material that will help forward interprofessional education, then you want to link that with another site that is doing something of the same so that they understand the differences and the same and the similarities between their work. Excuse me. In Canada and in the United States, we've been working on a competency framework now for at least 10 years. We refreshed our framework this year, and you can find it online, www.caic.ca. And we really need to develop that competency framework as the basis for a curriculum around interprofessional education, because we work on competencies that, I mean, there's a lot of discussion about competencies, but we work on competencies when we're thinking about interprofessional education. And the framework is a really beautiful framework. It's a work in progress. We can still improve it, and we will improve it, but you've got to have a competency framework in order to develop the core. And then make sure that you have an active virtual social network. So now we have an organization called Interprofessional.global, which is a confederation of 13 different organizations in 13 different countries or collections of countries. Really, really important, because when you know it's there and you can go to the site and you can see people doing things that are of value to you, that social network is incredibly important. And then, of course, to support student-led organizations, because students are our best voice in moving interprofessional education forward. A research program. We now have some very good research programs, and they have to be rigorous, multi-institutional if we can do it, cross-sectional, longitudinal, very important. Only, as we all know, it's quite difficult to do longitudinal studies because of the funding that's involved. So we see lots and lots of cross-sectional studies, which are in fact giving us excellent data. But there are a couple of longitudinal studies which show us that downstream, after students have been involved in the learning process, you can actually see the results in the way in which they practice. So using robust tools, working on organizational change, delivery of care, blah, blah, all of these things, all of these topics are topics on which you can find now research that is being done, has been done, or is being proposed. And I think that a good interprofessional education program is a program that is based on a really good research program, so that you can see right from the start that you're actually on the right track, you're getting the right information, and that you are in fact changing systems. So in practice and care, I think that we have lots of data now, the need to understand, document the monetary and fiscal elements of IPE in collaborative person-centered care. You know, what is the return on investment? Health is not a cost. Health is really a benefit, and people and politicians quite confuse this. It's not a cost. The better the health care of the population is, the better the GDP, the better the general well-being of the population, etc. So we need to understand, as we do interprofessional education for collaborative person-centered practice, you know, what are the fiscal, what are the monetary elements associated with that? Now, we have very little data on this at the present time. You can imagine it's a very, very complicated problem, you know, and it has many layers and it goes in many directions. And I think it'll be some time before we get the kind of data that I would like to see that says, yes, look how much money we are saving by doing this. And by saving that money, we can use it for something else. So understanding really important. And having that that notion that there is a really good return on investment really does support a central tenet of the United Nations report of 2016, which you may or may not know, but was a very good report, which did point out healthcare is a benefit. It's not a cost. And there'll be lots of people say, well, you can't do this because, you know, it's not going to. We have to have that, the evidence, the financial evidence, as well as all of the other evidence to say, no, actually, we now have really good data to say when you put groups together, group of professionals together, they'll give you really fantastic service. Okay, so then moving to high quality care, well, we know that health services have to be collaborative. And you may say, well, aren't they? Well, I would suggest you look at your own organization and say, are we really collaborative? They have to be better managed. And we have lots of data and from all over the world to say, well, health, it's, you know, the health sector, health social care sector is so complicated. Managing it, you know, is like putting cats on the back of a flatbed truck. It's really difficult, but services have to be better managed if we're going to improve quality of care. And when they're better managed, it usually means that you have pretty good teams of people collaborating within the organization. The delivery must be better. It's really a problem certainly in my country, in a number of different areas. Primary healthcare is always a huge issue. And we're trying very hard to think about how to better deliver primary healthcare, but all health services need to be better delivered. And you can think of things like access, you know. Why is it that it takes so long for me to get something done to my knee or to my shoulder or to my hip? And then we need to be sure that we can manage a continuum of care, that when a patient comes into the system, their care doesn't end when they leave the system. Their care actually goes out into all of the social determinants which are there to support them with things that you can't do in the acute care sector, but are absolutely necessary if they are to recover fully. So the continuum of care sometimes gets lost. We get lost trying to think about it, but it's really important. So when we sit down with a team and do discharge planning, what we're really talking about is this issue, continuum of care. You know, does the discharge really cover what it is that the patient will need? And that's when we're thinking, what is the team once you move out of an acute care setting, for example, that needs to be available to the patient in order that they have had safe, high quality health practice and care. And then the services for higher quality, the principle, the two core principles, well, it has to be across different levels, sites of care. And as I said, it has to be within and beyond the health sector so that it does in fact recognize as determinants. And we should know what those determinants are before the patients come to us, actually. You know, when a patient comes into the office of their primary healthcare physician in the morning, the first question should be, well, so how are you today? How did you get here? You know, did you have a difficulty? How was your night? Instead of saying, well, what's wrong with you? And then we have to focus on the health of the population throughout the life course and not the needs of professions. I hate to say it, but, you know, when I look at scopes of practice and accreditation and so on, I'm struck by the fact that this looks like it's about professions. It doesn't look as though it's about the health of the population. But in any event, we need to focus on the health of the population throughout the life course, which means, again, looking at where the social determinants breaking down: clean air, clean water, good education, healthy living, okay? And what we have learned in Canada over the last 15, 20 years is that the patient's voice has to always be front and center. The line that they give us is nothing about us without us. And we have a very strong patient voices network, both in my province and in the country. And high quality service, excuse me, is dependent on that patient voice being present. Creating a policy platform. We have to be sure that we engage, encourage, and reward the practice community. Those people in practice who are providing educational opportunities for our students prior to their entry to practice. So we have to recognize the work that those people do in order that the next generation of professionals goes out well qualified. When we start on any one of these programs, we have to be sure that there's a good business plan in order that we can be assured that there's going to be long-term sustainability. If there's not a good business plan, believe me, that's it. It's over. You know, it's like, oh, we'll be with you for 2 months and then it's gone. So it's an interesting problem. Again, it's to do with financial and monetary matters, but very important. Have to think about, well, there's a lot of complex activities associated with IPE, IPCP. You know, which are the ones that should be at the top of the list to start with, and then second and third and fourth, prioritize. And then, of course, selecting some strategic homes for startup and ongoing programs. Really, really, really important. You know, who is it that is going to enable interprofessional education for collaborative person-centered practice to move forward? We've worked very, very closely with our family physicians because they are right there at the coalface. And they are the ones who will be strong supporters of people learning together to work together, because in residency programs for family docs, for instance, they see lots and lots of different health and social care professionals and know that, you know, they're going to have to work with those people when they see a patient who needs a hearing aid, for example, or vision care or physiotherapy. So selecting a strategic home to start up a program is really, really important. In my province of British Columbia, we're working on integrated collaborating centers, which are incredibly interprofessional. And that's been a deliberate activity by our provincial government. In a number of different reports, 2016 report I mentioned from the UN, Health Workforce 2030, which was put out in 2016, Global Strategy on Integrated People-Centered Health Services, and then the WHO Workbook, Social Determinants of Health, which actually was started in 2017, but didn't really get published till last year. But you can go online and you can find all of these at the WHO website. So I think in conclusion, I now see that IPE-CP is part of education, learning, practice, and care in a lot of different countries on all continents. Now, it's not huge, you know, it's not all over the place yet. It's not embedded in the system, but it's there. And it doesn't matter whether it's a high income or middle income country, we can see it emerging, and we can see it through our federation, Interprofessional.global. And what we know from looking at those programs that are in place is that given those things that I've talked about previously in this talk, you know, what the principles we should have in place, et cetera, IPE-CP really is resilient. It really captures people, practitioners' imagination. It captures their professional accountability, the way they see themselves. And I think it's been a very interesting journey, but we still, of course, have a very, very long way to go. So I'll leave you with this.